want to thank everybody both in person as well as from telehealth land. There are quite a few people who still have not muted themselves, and it would be much appreciated if you're either through WebEx or through telehealth, if you would be kind enough to mute yourselves so that we're not hearing all of your various background noise. Thank you. I'm Dr. Wong, Alex. I'm one of the infectious disease docs here in Regina, and I was asked today as part of AIDS Awareness Week, which was last week, World AIDS Day, which was yesterday, and Aboriginal AIDS Awareness Week, which is this week, to provide an update in regards to HIV in the province. I'm just going to answer this because my wife is in the hospital right now and she wants to know. So I'll just text her and let her know where I am so she can come and watch me and provide inspiration. Okay, so I want to thank Kim and the rest of the organizing committee for the opportunity. I want to basically begin by acknowledging that I am currently on Treaty 4 territory, we and the homeland of the Métis, and I'm going to just provide disclosures. In the meantime, can we bring the volume down here? Lisa, I don't know if that's the Lisa I know. Can you please mute? Okay, anyways, these are my disclosures and we're not going to ask for more muting going forward. So I want to, over the course of the next 45 minutes or so, talk a bit about the HIV epidemic and some of the other challenges that we currently face in Saskatchewan, which are multi sort of pronged. Talk a bit about some of our clinical characteristics and our outcomes to date here in southern Saskatchewan, and talk a bit about local progress towards the WHO 90-90-90 targets and some of the things that we've tried to do where we found some successes and where we've had some challenges. And then I lastly kind of want to provide a bit of a sort of state-of-the-art update just to kind of update everybody and inform everyone in regards to the current sort of landscape of antiretroviral therapy, HIV treatment, and prevention science as well. So let's begin. Most of you have seen this slide already. It's my standard slide talking a bit about how our epidemic is unique, and it's unique because it's driven by injection drug use compared to the rest of the developed world, where the HIV epidemic is predominantly one of men who have sex with men, followed then by heterosexual transmission. Obviously, worldwide, the majority of transmission occurs in sub-Saharan Africa, which is largely heterosexual transmission and vertical transmission. That's the MTCT for maternal to child transmission. Okay. So again, I mean, what we have in Saskatchewan is not necessarily an epidemic of HIV or hepatitis C or bloodborne infection, but rather an epidemic of injection drug use, which disproportionately affects challenged and marginalized populations, both in the urban setting as well as rural and remote reserve settings as well. And unfortunately, this disproportionately affects those who are most vulnerable and those who are most marginalized. Historically, how it began was largely with the use of injection cocaine, much like it did on the downtown east side. And the dynamic of injection cocaine is just largely one of chaos because people are not able to get essentially cocaine that was quote pure enough to basically do in any other manner. So they would inject, you would get a very transient high, and then you'd have to inject again and again and again. So it wouldn't be uncommon for people to inject, 10, 15, 20 times a day. And with minimal or limited access to needle exchange and clean equipment, that obviously sets the stage for a lot of chaos. And so now, interestingly, some of the dynamics obviously have changed in the community. We obviously still have a major opioid epidemic and all of the various sequelae of opioids, including overdose. But unfortunately, we now have crystal methamphetamine as the stimulant, not necessarily the stimulant of choice, but more the stimulant that is most readily and easily available. It's cheap, it's locally manufactured, and it creates chaos. And I was chatting with my colleague Maurice Markinton in Saskatoon. He described it as almost like, for a subset of people, essentially disinhibiting people and turning people almost into animals as opposed to human beings. And so we've had people, be violent to themselves as well as to care providers. And we've had people that have suffered some very unusual and disturbing mental health sequelae as a result of presumably the use of crystal methamphetamine. And so it is a very different dynamic. And unfortunately, we are still trying to sort out how to medically manage crystal methamphetamine addiction right now. There is no clear sort of approach to management. I was just chatting with my colleagues in BC. I was just in Victoria and Vancouver last week. And again, even at all the major addictions meetings, there's still a lot of controversy right now what the best approaches are to managing methamphetamine addiction. You know, I don't think there's really an urban or rural divide at this point in time. At one point, there was really with more prescription drugs being abused in the rural and on-reserve setting, but I think it's now very uniform. I think regardless of where you go, you have a large amount of opioids being used, predominantly prescription opioids, and obviously fentanyl and various cuts of fentanyl and heroin, and then obviously you have crystal meth as well as being the driving pieces. So this creates chaos, and this is what the challenge is. So I decided to add a couple of slides to my usual sort of spiel about all of this, because I'm slowly getting in to the addictions medicine space now and seeing some, you know, more firsthand of some of what addictions and injection drug use leads to. And so, you know, I'll just kind of make the obvious statement. I'll say widespread use of injection drugs in our province and everywhere drives serious health consequences for all affected persons and major downstream health costs for our system. So there's just all sorts of sequelae that we are seeing on a day-to-day basis, and it all hits downstream, you know, and it's what we're dealing with in the acute care setting literally all the time. So poverty, homelessness, food relationship insecurity, violence, incarceration, we deal with all of this. I already talked about some of the mental health sequelae, more problematic now with crystal methamphetamine in play, efficient transmission of bloodborne infections, acute infections, which we deal with all the time. Part of my motivation to try to get into the addictions medicine space was to be able to better try to intervene in the acute care setting when I have the opportunity to do so, usually when people are in medical crisis, like when they're in the ICU or when they're, you know, admitted to the wards. Usually that's a bit of a wake-up call, like, oh boy, this is kind of spiraling out of control. I'm really sick here. So it gives us the opportunity. And then obviously fatal overdose, which is a major challenge. We've had many people in our HIV positive cohort who have died suddenly, presumably of overdose. The most recent was a young woman in her mid-30s who was otherwise doing just fine, whether it was opioids or otherwise. And so, you know, this is all of what it is that we're dealing with. And again, now that I have an opportunity to do a little bit in the addictions medicine space, I'm seeing a bit more of some of all of the rest of these challenges as well, and trying to understand how best to manage it in an interdisciplinary manner. And this is not just down in the south, obviously. This is literally everywhere across the entire province. And so what do we need to do? We really need a comprehensive and collaborative interdisciplinary approach. This is not just about like trying to pick off like the HIV piece or the hepatitis piece or the endocarditis piece or the mental health piece. I mean, it really requires a collaborative, you know, full scope approach in order to actually deal with the problem in a sustainable way that is going to lead to meaningful change. You know, and I only see this now, 7-8 years after being here and focusing largely in HIV and viral hepatitis, the infectious sequelae. I realize now that unless we deal with all of these other pieces, including harm reduction, including overdose prevention, including mental health and addictions management, chronic pain management, and all the rest of these pieces, that we're not going to actually comprehensively and sustainably make any progress. And so I'm just listing the gamut of everything that we need to do. It's obviously easier said than done, but all of this is entirely doable. And I just, again, came back from British Columbia, where I mean, they have comprehensive supports in place that took 15 years to build, but that is ostensibly what we need to actually build in the province here in order to meaningfully make progress. Otherwise, it's just going to be piecemeal stuff, which is not really going to address some long-term challenges. And so I'll just say mental health and addiction supports, interdisciplinary management of chronic pain everywhere, not just, you know, in Regina, harm reduction services. I left safe injection site out on this list, but as you all know, there's going to be a safe injection site, which is going to be opening relatively soon in Saskatoon. So NSP stands for Needle and Syringe Programs, education on safe injection practices, take home naloxone, both inside and outside healthcare facilities for patients and providers. Obviously, the HIV hepatitis piece, and then trauma-informed and community-driven intervention. Again, I've tried to slowly understand these pieces around trauma and generational trauma, and it is beyond anything in terms of complexity that I've kind of really had any understanding of. And so I think that my somewhat naive approach years up to basically about this year was just, you know, it's good enough for me just to treat everybody the same, treat everybody with respect, treat everybody with dignity, and that's all. But now I'm beginning to understand that some of the pieces that a lot of the patients that we see and deal with have witnessed and dealt with is unlike what most of us sort of quote unquote normal people could have any perception of. And so having some understanding of that degree of trauma and trying to also appreciate how that plays into day-to-day decision making and how we can then try to provide better care is very important. And so this is something hopefully over the course of the next year or two that we're going to be able to do a little bit better on in this space. And then lastly, I would say, again, I mean, I was talking in BC, and they're, you know, they've got like a full addictions medicine fellowship, and, you know, there are people from Saskatchewan that have gone to BC, completed this fellowship, and actually then stayed in BC. And so I think, you know, looking at us, looking at what we really need to really engage and motivate the next generation of care providers. And I don't just mean doctors, I mean like everybody, you know, to really look and have a desire and a passion to work with this challenged population. It is exhausting at times, but it can also be some of the most rewarding work that we could possibly do. So, and then the last thing that I will say is that there's obviously major inequities in terms of access to care that exist largely due to geography and some of the system challenges, and that we need to address these as well. So this is pretty much like the line list of things that I think need to happen. And, you know, for better or for worse, I think we're trying to slowly, you know, in little bits and pieces, work on trying to address each of these. And I realize that there's probably things that I've missed. I would be open to getting feedback in terms of things that I have missed. But this to me is a more comprehensive approach to dealing with the problem, as opposed to saying we just need to test everybody for HIV and Hep C. Is that fair to say? Thank you. Okay, so I just figured I'd throw that out there, and hopefully nobody cuts my wrists off. So let's talk a bit about the ID clinic. So I work in the clinic. We have some people here in the clinic. It's a tertiary level clinic that serves about 500 persons living with HIV, predominantly in southern Saskatchewan. And so we have a interdisciplinary team consisting of nurses, pharmacy, social work, dietary, and various community outreach partners, all very, very important, as well as research coordinators and nurses, and finally, physicians. We've had a comprehensive database in place since 2014, which has allowed us to sort of better track all of our various outcomes and our quality of care indicators, so that we could then understand, at least at a high level, the effect of some of the interventions that we tried to put in place, and whether or not it made any difference, or whether it was just a giant waste of time. So what I'm going to do is just show you some of the most updated data that we have just from September of 2019, just in terms of the demographics and high level sort of clinical pieces.
Stroke alert and emergency,
Just gonna
10
wait.
minutes. Stroke alert and emergency, 10 minutes. Stroke alert and emergency, 10 minutes.
And then we're going to go through some of the clinical data. So I'll start by showing this. And if you look in sort of metropolitan Canada, so I'm thinking about like Toronto, Vancouver, Montreal, like big cities, and you look at the cohort, what you're going to see is you're going to see a much, much higher proportion of older men, okay, and men in general. And, you know, the curve here is, you know, kind of shifted all this way because we have a much younger cohort overall. You know, well over half of our individuals that we see are under the age of 45. And then again, what we see here is dramatically different. If you go to large clinics in downtown Toronto, Montreal, Vancouver, you're going to see probably like 85, 90% men and 10, 15% women. And here it's a 60-40 split. And the other thing that you see, so I really need to change this graph to make the blue men, but blue is actually women here, and you see a much higher proportion of young women. And then as you get older, you see sort of the older sort of men and the MSM sort of population kind of come through. So this is very unique in the country. And then self-declared ethnicity, a large proportion, 52% of individuals self-declare as Indigenous or Métis.
Stroke alert and emergency, 5 Stroke alert and emergency, 5 minutes. Stroke alert and emergency, 5 minutes.
I guess they'll give another announcement when it's 2 minutes. So anyways, so this is ethnicity and then primary risk. 55% have injection drug use as their primary risk. And in case you're wondering how we define primary risk, anybody with any background history of injection drug use, that became their primary HIV risk, because obviously people who inject drugs also have sex, for example, but because of the efficiency of transmission through parenteral means, if anybody had either a current or background history of injection drug use, that became their primary risk overall. And then the overall years of HIV positivity, really the vast majority of our cohort came through in the last decade. Co-infection with hepatitis C is just largely just an indicator for concurrent injection drug use. And so not surprisingly, we have a relatively high proportion of individuals who have hepatitis C antibody positivity. And I will show that we are making some progress in terms of, so we have 281 individuals who are hepatitis C antibody positive. We've actually had open access to hepatitis C direct-acting antivirals since April of 2017 for co-infection with HIV. And despite that, we still have a relatively large proportion, almost 120 of our co-infected individuals have yet to be treated for hepatitis C, or there's also a subset of individuals who we've treated and then reinfected as well. And now we're basically planning to retreat them again. So we, again, have some progress that we need to make in this space. So that's just a bit of a background overall, a very unique epidemic that we see here. And what I would probably say is this largely mirrors what you would see in Saskatoon. The numbers would probably be more pronounced in terms of Indigenous ethnicity as well as injection drug use and hepatitis C co-infection in most parts of Saskatoon, and then certainly going to PA and northern Saskatchewan, you're going to see a much more pronounced effect as well in terms of transmission through injection drugs. And so again, I mean, our data is not super consistent at a provincial level, but it wouldn't be uncommon to see rates as high as 85–90% in terms of hepatitis C co-infection in northern Saskatchewan, which again just mirrors how transmission is occurring. Okay, so how are we doing? So I want to provide a little bit of background here just in regards to some of the quality of care indicators that we've tried to use and track over the course of the last several years, because the definitions actually are important. And if you define things in ways that are perhaps a little more loosey-goosey, then maybe your numbers kind of go up. But in the end, all that kind of matters is viral suppression. That's really the main thing. So the first quality of care indicator that we followed for the last 5 years is the so-called HIV cascade of care. And what this is kind of like an idealized framework of how you think that a patient should sort of travel through the healthcare system to get to the end goal, which for almost everybody who's HIV positive is achieving a fully suppressed HIV viral load. And for virtually everybody, what that means is that you have to take HIV medications in some sort of reasonably consistent fashion in order to achieve a fully suppressed HIV viral load. There's a very, very small subset of individuals, like I think we have like maybe 2 or 3 in our cohort who we call elite controllers, or special individuals that are actually able to suppress their virus and maintain virologic suppression despite the fact that they're not actually taking HIV medication. Okay, but that's a very, very, very small number. Otherwise, like most normal people would not suppress their virus unless they were taking some sort of medication in some sort of way. Okay, so what happens if you have HIV? So first of all, you have to be tested, right? So if you're not tested, you can't be diagnosed, so you have to be tested. And then once you get tested and you're found to be positive, then you have to go to the clinic and be seen. And then you have to keep going back to the clinic sort of over and over and over again, because right now we don't have a cure for HIV. And then lastly, you need to be on medication, and then you need to achieve a suppressed viral load. So this is sort of the idealized approach. And the reality is that many of the patients that we see don't necessarily have this nice, neat, linear progression through the cascade where they're like, oop, I'm diagnosed, oop, I go to clinic a week later, oop, I get put on medication right away. They get put on medication, then they disappear for a couple of months, then they come back, then they need to be re-engaged, then they go back on medication, then they get suppressed, then they disappear again. And it's kind of referred to sort of like this cascade churn where, you know, a lot of our people, they don't just kind of get to the end and stay at the end like in a lot of other centers. They get to the point where they're suppressed, and then something happens in their lives that creates some degree of instability or chaos, and then everything kind of goes to poop again, and then you start from scratch, right? And so this is kind of like this never-ending process of churn that happens, and it's much more pronounced in our settings because of some of the sequelae that we talked about earlier in terms of chaos, food, relationship insecurity, housing, poverty, it never ends. Okay, so with all that said, these are provincial level definitions, which I do not believe have changed. These were defined in 2013, and they remain the provincial level definitions, which in theory, all clinics, when reporting data, should be using. So to be engaged in care, we know that the sooner that you get seen and that you get quote unquote engaged in care in an HIV care setting after you're diagnosed, the sooner you get engaged, the more likely you are to have a good outcome, which is not entirely surprising, right? Because if you're reasonably high functioning, you're motivated to be treated, you're going to want to probably get in pretty quick because being diagnosed with HIV is not a small deal. But on the other hand, if you have all of the other concomitant sort of chaos, poverty, homelessness, all the other pieces which are driving your life and your life circumstances, then you're probably going to prioritize coming to the clinic a little bit less because you're too busy like trying to find a place to live or trying to find food for you and your family or trying to not be beat up, you know, at nighttime, for example. So those are all the pieces that ultimately take precedent. Again, there's a lot of concurrent chaos. And so that again is a predictor of outcomes. Retention we defined as 2 made appointments greater than 90 days apart in the last year. On antiretroviral therapy is a bit of a loosey-goosey one. It just means that you have to have been given a prescription for antiretroviral therapy in the last 12 months, but that doesn't necessarily mean that you even filled it or that you're taking it. In the end, for me as the clinician, all I care about is whether or not you achieve virologic suppression. And this definition of virologic suppression means that you had a viral load less than 200 in the last 12 months. And so we have a number of individuals who are still taking medications, but for example, have not gotten lab work done recently. And so they may not ultimately be defined as being suppressed because of the fact that their last HIV viral load was not done, say, for 12 months. Okay. So with all that said, here's where we're at. Okay. So linked within 3 months, retained in care. Again, we have some ways to go in terms of improving this. On antiretroviral therapy, looking at our entire database, about 85% have been given a prescription. So that means 15% were not given a prescription and presumably not on medications. And then finally, of the entire clinic cohort, based on the definitions that we've said, about 66% of our patients are virologically suppressed. And these numbers have been steadily declining over the course of the last year and a half. Okay, and there's a variety of different reasons for that. I think part of that is being driven by some turnover that we've had in our clinic with staffing and so forth. And again, when you have certain people that have a lot of experience, they move away from the space, you know, you have to retrain. It takes a little bit of time. Your numbers take a bit of a hit. But I think the other big piece is the fact that there's a lot of chaos being driven by crystal methamphetamine. And we have a lot of individuals who are very, very stable, who all of a sudden just disappeared right off the face of the map. And a lot of that was being driven by crystal meth. And we're in this process of trying to re-engage all of these individuals. So this is kind of where we're at. And again, I'm not showing the longitudinal data, but the bottom line is that we were up and doing probably really, really well kind of in 2017, 2018. And we've seen now this steady decline. So with all that said, we're going to move now to the second sort of quality of care indicators, which are the WHO so-called 90-90-90 targets. And again, some of you may have heard of this in some high-level way. I'll just very briefly explain what the 90-90-90 targets are. So the WHO by 2020 says that 90% of individuals with HIV should be diagnosed, which is a difficult number to actually measure because you don't actually know what the denominator is in the community of individuals who are HIV positive who've not been linked to care or engaged in care in any way. And so, you know, the traditional rule of thumb in community in most settings is about 20 to 25% of persons undiagnosed. And that number, we have no sense of what that number is locally, regionally, or provincially at all. I hope that number is low, but I worry that that number is high, okay? And some of what predicts these numbers usually is your transmission rates, and we're gonna show your because if your transmission rates continue to go up, despite the fact that you're quote unquote engaging a lot of people in care, that means obviously there's a lot of individuals in the community who are either undiagnosed who have viremia who are transmitting, or you have people obviously lost to follow-up who are not on medication with unsuppressed viral loads who are transmitting as well. Because if you found everybody and you put everybody on virus, I'm not gonna talk about U equals U, but U equals U is undetectable equals untransmittable. So what that practically means is that if you have a suppressed viral load, essentially less than 200 copies per mil, you cannot transmit your virus sexually, And the likelihood of you transmitting your virus parenterally, like through injection drug use, is probably also exceedingly low. Okay, so this is this concept of treatment as prevention, which was pioneered by our colleagues in BC. So just to get back to the 90% of individuals with HIV diagnosed, 90% of persons diagnosed receiving antiretroviral therapy, and then finally 90% of individuals on antiretroviral therapy are actually virologically suppressed. So where are we at? And so again, what we've seen over the course of the last year, and kudos to Molly Trecker, I don't know if she's listening, who's our research scientist, who's pulling all this data out from our database. But we've seen a steady decline as well in terms of our on-ART and suppressed. At one point, when I presented this data last year at this time, basically, we were actually close to 90. We were at 89 point something percent for on-ART, and we were at about 83% for suppressed. And so we've dropped over the course of last year, I think for the same reasons that we just kind of talked about. There may be some other factors at play that we're not necessarily aware of either. So, you know, we need to kind of rebound a bit, and we've got some stability in our clinic now in terms of staffing some new persons on the team who are full of energy. And so we're hoping that we're going to be able to kind of rebound some of these numbers going into 2020. So I just want to show you the incidence rates of Canada, Saskatchewan, and Southern Saskatchewan, or the former RQHR now. So I really need to change the colors on these slides, but the green, I really should change it to red, is Canada. So you can see that these numbers in terms of incidence rate of HIV per 100,000 tested, 100,000 population, sorry, is still very low. So we're down at about 6.5 persons per 100,000. But then when you look at the Saskatchewan numbers, we got down to about 9.8 in 2014. And since then, we had a big uptick, and it's kind of plateaued perhaps a bit. In our 2018 numbers, which were released about a month ago, we're at 14.1, which remains about 2.5 times that of the Canadian overall incidence rate. So now I'm going to superimpose the RQHR numbers, which is in orange. As I said, I need to change these colors, but you can see, like for RQHR, when you track this graph, that when we got to 2016, we were almost at the Canadian incidence rate. And so we were all ready to give ourselves pats in the back and, you know, high fives and say, hey, you know, look how great we are. And then it kind of went to poop. So we've had a big uptick in 2018. We had another big uptick so far in 2019. This is our incidence rate as of about mid-November of 2019. So this number will be higher because there's still a month and a half to go, and presumably there will be a few more people who are going to be diagnosed with HIV. August was a bad month for us. I think we had something like 16 or 17 new positives in 1 month, and so we were all just kind of freaking out. Amazingly, that kind of disappeared. And I was again chatting with our BC colleagues about some phylogenetics. There was a lot of local transmission, and why this remains unclear at this point in time. So that's kind of where we're at, and we are probably on track now to exceed the provincial incidence rate going into 2019, which is unfortunate considering where we were, you know, obviously in 2016. So just to highlights the fact that, you know, it's a never-ending effort that's required, and, you know, you have to maintain constant diligence. Some of the things that we've tried to do locally, again, I mean, I'm not going to be entirely inclusive of everything that we've tried to do programmatically. I think one of the things that needs to be highlighted is the fact that the medications have actually gotten a lot better. So over the course of the last, so this is back in February 2014, and this is essentially the number of patients that we've had on various classes of HIV medication. And the main thing to look at is the green line here, which is the proportion of person on integrase inhibitors. This is the next generation of sort of medications, which are very favorable. They're easy to take. They're well tolerated. They have what we call a high genetic barrier of resistance, which means essentially that if you are less than optimally adherent to your medications, you're less likely to develop antiretroviral resistance, which is really important in our setting because we have a lot of individuals who don't take their pills perfectly. And, you know, so when you contrast this to where we were back in 2014, a lot of patients were taking what we call protease inhibitor medications that had more issues with tolerability. They were much larger pills. You had to take multiple pills each day. And so, you know, that definitely is something which has played a role in terms of us. Like if we didn't have advancements in terms of our antiretroviral therapy, it's hard to know exactly where we'd be at this particular point in time. And you can see that the other classes of medications have gradually faded away. And this mirrors what's happened in a lot of other settings across the developed world. This is the jail, which we attend, and not only to manage HIV, but also viral hepatitis. And some of the most important work that's done in corrections is really linking and testing and engaging people in care. And then we have a consistent social work presence now in the jail as well, which allows us to really provide some wraparound discharge planning, which is so crucial for persons who are exiting corrections, to try to have some clear plan in place, because it's not like the system makes any plans for them. They essentially get told that it's time to go. And so we've had people literally, you know, get discharged or get released on a -30 day in like socks and sandals and shorts, because that's basically what they had in August when they were admitted into the correctional facility. So how exactly are you and this place, I don't know if anybody knows where RPCC is, but it's in the middle of nowhere, right? So up near the co-op refinery, so to actually like get your way back into town with nothing is not entirely a trivial process. Okay, just to sort of highlight it a little bit and put it in perspective. We're in various inner city settings, including agonist therapy settings, harm reduction clinic, and so forth. We over the course of the last 2-3 years have, I wouldn't say pioneered, but worked on having more community nursing presence. So essentially we have a couple of community-based nurses who essentially work under protocol and have the ability to manage essentially all of the hepatitis C cascade and much of the HIV cascade, short of actually prescribing antiretroviral therapy. And they work under protocol under quote unquote supervision from myself. They largely function independently in the community. So, you know, one nurse who is soon to retire, I'll just acknowledge her. I don't know if she's listening, but Deb Roger, who's been in this space for over 2 decades now and has basically been a stalwart of our system. She sadly is going to be retiring. I understand you have to retire, Debbie, but we will miss you, and we will hope to continue to do the good work that you've done. She's administered hundreds of vaccines, tested hundreds of people, seen thousands of people in the last 2 years in a variety of inner city settings, and provided access to care and support that would not otherwise have been possible. And so for us to continue to keep that position in place is extremely valuable and important. This is methadone. Obviously, I should probably put a picture of Suboxone up now as the preferred agonist therapy of choice. And then there's lots of additional work. My colleague, Dr. Skinner, and his Wellness Wheel team are doing a lot of work on reserve and in rural settings. We have a lot of work being done with inpatients and case management with our pregnant women as well. So again, this is just to highlight the fact that we've made some efforts at a programmatic level to make some progress. And we have made some progress, but we obviously still have lots to do. So I would say modest progress has been made, but we need obviously additional supports in place, and that's a complicated dynamic. We do need clinical data, and so having eventual provincial level data would be extremely valuable for us in terms of trying to understand what interventions work work best and are most cost effective. And the reality is that some interventions that work in some settings may not work in other settings. But I think we've learned very clearly here in Regina and southern Saskatchewan that community-based work and removing barriers to access to care, or eliminating barriers to access to care, is crucial to maintaining good engagement with your population. So that's just sort of our little spiel. I've got about 15-20 minutes left. So I'm gonna stop there just for a moment. Any questions from Telehealth Land or from anyone in regards to kind of some of the work that we've done so far? No? Okay. So I'm going to take the last probably about 10-15 minutes. I'm just going to provide, hopefully, everybody that's listening with a bit of a state-of-the-art update in regards to kind of what's new and cool in antiretroviral therapy and HIV treatments, and what's kind of new and cool in HIV prevention. Okay, and just came back from the fall meetings and so forth, so I'm reasonably up to date in this space now. So what's new and cool? So what are we currently doing in terms of antiretroviral therapy in 2019? Basically, almost everybody who is a newly diagnosed person living with HIV, with one exception, which is women of childbearing age wishing to conceive and potentially pregnant or are pregnant. That's the only exception where we may still be looking at some of the older medications, because there's still a small question in regards to safety with some of the next generation integrase inhibitors and neural tube defects. For anybody listening, I would encourage all of you, if you have an interest in this space, to tune in next week. I believe next Tuesday is going to be the 10th of December. My colleague from Oak Tree Clinic at BC Women and Children's Hospital, I wouldn't say my colleague, one of my experienced colleagues, Neora Pick, she is the clinic director for BC Women and Children's, and she will be here in Regina to provide an overview and state-of-the-art update in HIV and women's health, including all of the current literature around what to do in that complicated space of women who are of childbearing potential, as well as women who are wishing to conceive or women who are pregnant. Okay, so Neora will be here probably in this space or the auditorium, I guess. The auditorium at the General, and that will be broadcast through WebEx and through telehealth. So please join us for that as well. So back to your regularly scheduled programming now. So I'm going to mention here that next generation integrases. So we have something called bictegravir, something called dolutegravir, paired with 2 nukes, basically is the clear first-line treatment option for all individuals, with the exception of women, as I had mentioned. And so the way that basically bictegravir is available is as a single tablet, bictegravir FTC and TAF. The trade name is called Biktarvy. It's a small red pill. It's about half the size of a multivitamin. Just to give you a perception of where that is. It's very well tolerated. Virtually no contraindications clinically, other than for if you have TB co-infection. Okay, but otherwise it covers everything else. It's an excellent drug for rapid start. We also have dolutegravir-based regimens, which we've used and have extensive experience with. So dolutegravir ABC3TC, which is Trimec, and then dolutegravir with the various FTC backbones, including Truvada as well as Descovy, still recommended as first line, very, very well tolerated and easy to take. What's some new and cool stuff? So we have 2 drug regimens now. So specifically dolutegravir plus 3TC as a single tablet is now available. So this is the first 2-drug antiretroviral regimen, which has now been approved by Health Canada as well as the EMA and the FDA for use in treatment-naive individuals. So the idea behind using less drugs is the theoretical benefit of being exposed to less medications over time, because right now, unfortunately, we have no cure, we have no vaccine. And so HIV is a lifelong illness. And so the idea of exposing people to less drugs over time may then reduce toxicity and improve tolerability over time. We have a regimen dolutegravir rilpivirine, which is Juluca. This became available in 2018 for switch. And then the other thing that some of you may have heard of is long-acting intramuscular injections with for HIV. And so we are doing the phase 3 trials here in Regina with long-acting cabotegravir, which is an integrase inhibitor, and rilpivirine. It will be eventually approved by Health Canada sometime in 2020 as a long-acting formulation given once every 8 weeks. There's 1 needle in each gluteus medius. It has to be done by a trained healthcare professional. And essentially this can substitute for taking medication, oral medication. So now you have the ability to receive 1 injection in each butt cheek once every 2 months. We have 8 patients in the clinical trial program. They've all done extraordinarily well and are extremely happy with the medications. The only question, not that, well, I think this is okay to mention in a public setting, is that it's not clear what the reimbursement of this medication is going to be like, because this medication is expensive. There's additional logistics required, and the company's asking for more money, I think, than the equivalent oral medications. And so, the public system asks questions around, like, why should we pay a premium for this medication? Basically, what makes this somehow better when the bar is so high for taking pills? And so we as care providers are arguing about the importance of having choice. There's a significant stigma piece around having to take pills on a daily basis, and there's a subset of our individuals who are very stable and engaged in therapy, maybe taking concurrent injections like depot or antipsychotic medications, for example, via injection, where this could potentially work very, very well. This is not necessarily a panacea for all the super unstable patients, because we have no clue what the heck happens if you give them 1 injection and then just have them disappear into the abyss. Theoretically, this could be a very, very bad recipe for resistance, because what happens with long-acting injections is that the drug levels slowly fade over time, and the recipe that you need for resistance is basically sub-therapeutic levels of drug in the presence of actively replicating virus. And so if you just give them like 2 injections and then they disappear off the face of the map and don't see you for 7 or 8 months, they could have low-level drug in their system for like 2-3 months in the presence of ongoing HIV replication. That could lead to high-level resistance. And we have no concept of what that looks like. Just a caveat for everybody listening in telehealth land that this is not something we would necessarily want to use for every single person, okay? So with all that said, we also have a new NNRTI available called doravirine. It's sort of like the next generation of that old class of medications, which included things like efavirenz and nevirapine, which were used back before I was a doctor. Again, I mean, this is a next generation NNRTI, which has now been approved through PCAPA, and we expect it's now already funded in Ontario and Quebec, and we expect that it will likely be funded here in Saskatchewan as well in the near future. So this is kind of what's imminently coming. There's some other cool stuff, at least for me as a HIV nerd. There's a new drug being developed by Merck, which is a dual mechanism of action on reverse transcriptase. It's a NRTTI, so translocation transcriptase inhibitor. It's cool because it acts against reverse transcriptase, but it actually has full activity even if you have like high level resistance at reverse transcriptase from being previously exposed to all the nukes in the past. And so for their phase 3 clinical trial program, which is going to be beginning at the end of this year, they're actually allowing patients with high level resistance to go into the program as a proof of concept to show that this drug is going to work. I also have a certain bias towards it because they actually discovered this stuff from soy sauce. I'm not kidding. I don't know actually what they did, but they actually licensed this compound from Yamasa, which makes, like, you know, when you go to the sushi restaurants, for those of you that eat sushi, you go to the sushi restaurants and you see the bottles of soy sauce, and there's like a red bottle and a green top bottle. That's like the Yamasa soy sauce. So they actually discovered this compound in soy sauce. So maybe that kind of appeals to my Asian roots. So in the end, we're excited to be part of some of the phase 3 programming with this. It's going to be paired with doravirine as a single tablet, and they're going to be comparing it against a variety of comparators beginning at the end of this year. The other thing that's mega cool about 8591 is it's a long-acting, super potent drug, and so they're actually formulating it for long-acting implant. So there's a contraceptive implant, which currently is not, I didn't actually know this, but I just literally found out last week, it's not currently licensed in Canada. It's got a trade name called Nexplanon, and it's available in the States. It's also available in Europe as a long-acting implant that goes basically under the skin, and it's good for a year. So it's an option that women have as opposed to doing depot and or IUD and other settings. And so they're actually using the same type of technology potentially as a long-acting PrEP implant, and they're looking at a timeline of 6 to 18 months as a PrEP implant. So currently PrEP, we're going to get into PrEP in just a moment, but currently PrEP requires that you basically take a pill a day, or that you take it on demand if you know that you're going to be sexually active within a couple of hours, and then you carry on sort of taking it. And so theoretically, this PrEP implant may actually allow for a single implant to go in, and then you could be good for as long as a year and a half without actually having to take pills. So this is some really cool stuff, at least for me personally, and we're hoping to be involved in some of the development program for these various options going into 2020 and 2021. So what else is available? So there's a Gilead subcutaneous capsid inhibitor. A lot of the data was just presented in Europe just about a month ago in Basel, but this is cool because it's subcutaneous. So theoretically, with a subcutaneous injection versus an intramuscular injection, this could potentially be self-administered by patients. And they just released data showing that they are going to plan for human studies with a Q6-month formulation. Now, the big question is what they're actually going to pair it with, because you can't just give one drug to patients who have HIV. So presumably they're taking one of their other compounds, likely their integrase, and trying to nanoformulate it. So we could conceivably by late 2020 have a human trial where patients may either self-administer or have administered a subcutaneous injection once every 6 months for therapy, as opposed to having to take pills. That could be really cool. That might potentially be something that could be interesting for our more challenging and chaotic populations. Okay. And lastly, there's 2 new compounds from GSK or ViiV. One is a broadly neutralizing antibody, so long-acting IV infusion. Again, the idea being that you could conceivably give IV infusion, and this could be good for as long as 6 to 12 months. So again, if you can imagine like getting an infusion and then not having to take pills for that long, as well as a maturation inhibitor, which is a pill, so a little less exciting, but a new class or mechanism of action. So all of these are new classes of HIV medications, a little less exciting for treatment naive individuals, but more exciting for individuals who are treatment experienced, who may not necessarily have as many options available. So again, we're excited. And hopefully the companies will bring some of these studies to Saskatchewan so that we can have some of our patients be enrolled in some of the development programming. The last thing I want to comment, this is kind of more for those of you who are in the antiretroviral therapy space and prescribing and monitoring antiretroviral therapy, is that there's been a lot of data on weight gain and integrase inhibitors, and I just wanted to clarify some of this because there's a lot of conflicting data. But the bottom line is that I think there's reasonably good consensus now amongst people that I would consider to be HIV antiretroviral therapy experts that this is real. There were 2 large prospective studies presented at various points in time in the fall. There was a paper in CID, which is Clinical Infectious Diseases, which is our big sort of clinical journal, like our clinical specialty journal, that was published in October. Paul Sachs was the first author. This was a Gilead-funded study. And then there was the ADVANCE trial, which I'll present briefly, which was meant to be an antiretroviral therapy study, but they looked specifically at weight gain as an issue. And so, you know, weight gain, so first of all, the caveat is that we see a lot of people who probably could stand to gain some weight, right? Just because of various lifestyle issues and challenges and so forth. And we know there's already really good data in the literature that shows that if you have more advanced disease when you present initially with HIV, i.e. you have a high HIV viral load or you have a low CD4 count, i.e. your immune system is weak, then you gain more weight as you achieve a suppressed viral load and so forth. But this is probably more of what we would consider to be like a return to health signal as opposed to something that's bad, right? And so, so we know that exists already, but we're talking about people who are at decent weight, like who already have BMIs that are kind of in the 25 to 29 range, who would be classed as being overweight, who are now kind of moving into the, you know, sort of obese category, or gaining 10% or more weight, okay? And so again, this is just to show that the integrase signal probably is real. We also have some data that shows that women gain more weight than men. Black people in general gain more weight than non-Black people. And again, if you have more advanced disease at baseline in terms of your HIV, that you're more likely to gain weight as well. So last year, there was a lot of data presented from cohorts and so on and so forth. There's a lot of limitations with cohort data that made me sort of be like, I'm not entirely sure whether or not this is real, but I'll just show you this prospective data. So ADVANCE was essentially a trial. I got a couple minutes here. I'll just explain really quickly. It was done all in South Africa, and it compared 3 arms. So standard sort of atripla, which is an efavirenz. This was kind of like the standard of care in sub-Saharan Africa for years, and then the newer sort of dolutegravir-based regimens. So bottom line here is one of the combos was dolutegravir plus TAF-FTC, which is this new sort of TAF compound, the new form of tenofovir. And then the other one was standard dolutegravir and Truvada. And the bottom line is you can stratify these out, and you can see whether or not you're a man or whether you're a woman, that if you got a TAF dolutegravir containing regimen, that you gain more weight compared to if you had a dolutegravir Truvada regimen where you gain some weight. But if you're in this efavirenz sort of atripla class, you actually gained minimal weight, relatively speaking. You can see that these curves are all close to being statistically significant. There's a bit of overlap sort of as you get out here to week 96. Now, this was not a trial designed to evaluate weight gain, but they did capture weights as part of the trial. This was meant to be like an antiretroviral therapy study, and the antiretroviral therapy component was actually published in the New England at the end of August. Okay, and so this is the ADVANCE data, and this essentially was a pooled analysis of 8 large phase 3 clinical trials that were run by one company called Gilead. There were almost 5,700 people in the overall analysis. And what they did was they stratified people out by whether or not you were a man or a woman. So here, this is female versus male. You can see that there's a bit of a difference, but you can see that there's an even more pronounced difference if you're either a Black woman or a Black man versus a non-Black woman or a non-Black man. This is all statistically significant at 2 years. And then this is just stratifying you out, whether you're Black or whether you're not Black. And again, you can see a significant difference here. These differences are hard to ignore. Now, there may be some concurrent pieces, socioeconomic pieces, other pieces that could explain some of this. When you look at the phase 3 programs that Gilead did, most of the persons who are of Black ethnicity were recruited from the United States, specifically the southern United States. So there may be some metabolic components, lifestyle components, other components that are confounding all of this. We don't necessarily know. These are questions that we're still trying to sort out. Not we as in me, we as in like the worldwide HIV, whatever people that care about this type of stuff. they're still wanting to try to sort all this out, and I am just along for the ride. Okay, and then this is weight gain. So this is looking at the classes of HIV medications. Red is the so-called integrase inhibitors that are now recommended as first line. You can see very clearly that there is a statistically significant difference. This is absolute weight gain in kilos, and you can see between protease inhibitors in blue and NNRTIs in green, there is a difference. Looking at the actual integrase inhibitors themselves, the newer integrase inhibitors, this big tegravir and dolutegravir that I talked about as being first line, actually lead to more weight gain compared to the older integrase inhibitors. And then lastly, looking at the backbone, TAF-containing backbones seem to drive weight gain more. We don't know whether or not this is more related to the fact that the old form of tenofovir maybe led to weight loss or promoted weight loss. This is all still up in the air and still needing to be determined. So the bottom line is that weight gain is real. And, you know, weight gain matters for some more than others. But if you're gaining, and I mean, I think anecdotally in my sort of little cohort of 280 to 300 people on therapy, I can think of at least 5 people, 2 Indigenous women, 1 Black woman, and 2 white men, one in his late 50s and the other in his mid 40s, that have all gained a lot of weight, as in I saw them 3-4 months after, and you could just kind of see it in their face. And you're like, something's different. Have you? And they're like, yeah, I gained a lot of weight, right? So, but the challenge is we have no idea what to actually do with these individuals. There's no data to support potentially switching their antiretroviral therapy or changing anything in terms of the space. So that's all sort of data to kind of tease out and be decided. So I'm going to finish off with PrEP, which is to say that PrEP works. And large metropolitan centers like Paris, Vancouver, San Francisco, and Sydney, who are all sort of global fast-track cities to achieve 90-90-90 by 2020, have all seen major decreases in HIV incidence. Vancouver, Joss DeWet, one of our colleagues in Vancouver, came to Regina, presented the local data. There's been a decrease of over 50% in HIV in MSM populations in Vancouver so far in 2019. This is all being driven by rapid scale-up of PrEP. And so we have obviously a smaller scale setting in Regina with about 150 to 180 people engaged through a pharmacy-led clinic, which is going really well as well. I talked about 8591 as a long-acting implant, which is going to be really cool. And then there was some data showing that Descovy, which is not ever going to be funded in Canada, is non-inferior to Truvada, but this is really not going to matter until it becomes genericized. So prevention is very, very real. And so we have a lot of work that we need to do going forward in terms of the treatment space, new classes, new formulations coming in 2020, and the science does continue to develop. But there is, unfortunately, still relatively minimal promising clinical data with respect to any type of HIV cure or vaccine, although there is some stuff being developed, and we expect to see some clinical trial data from Thailand regarding a new vaccine at CROI, I think, which is going to be in early March in Boston. We're excited to see that. And lastly, HIV prevention. We know that PrEP works. We need to roll it out as widely as possible, and we need to start thinking, especially in our space here in this province, looking at HIV prevention beyond just the traditional high-risk MSM population, looking at individuals who inject drugs and persons who are practicing various forms of both safe and unsafe intercourse. So with all that said, that's pretty much it in terms of my overall update. I'm happy to take any questions. I've got a couple minutes to go here. Thank you for the attention and for the opportunity to present today. And happy AIDS Awareness Week and happy Aboriginal AIDS Awareness Week as well. Questions through telehealth at all? I see a couple of familiar faces. I'll just say hi to Shelley from PA. Nothing, everybody's just blown away. Anybody here? Okay. I assume that silence means that I explained everything so well that nobody has any questions. So I'll let it go, and please carry on all the great work that all of you are doing in your various settings. We still have a tremendous amount to do in this space, in this province, and I look forward to working with all of you in different capacities to achieve those goals. Thank you.